My name is Richard Baxter, and I'm a board-certified pediatric dentist and diplomat of the American Board of Laser Surgery. We've used Light Scalpel for 4 years now. We've really enjoyed it. It's been such a helpful tool in our office. We started out with a diode laser. For soft tissue procedures, I think the CO2 wavelength is the best. So then it comes down to Solea or the Light Scalpel, and I guess there's a Deca too that's kind of older and they're kind of revamping now. But for the Light Scalpel, the flexible waveguide makes a huge difference. So it's much easier to use. I've demoed some of the other ones, the articulated arm, and it just seemed kind of clunky compared to the diode laser we had before. The diode laser, you had to pay for the disposable tips every time, around $7 a piece. So it's almost like a toner and printer issue where you can get the cheaper printer, but then you pay for it in the toner, versus with the Light Scalpel, it actually turned out to be more economical, and it paid for itself in the first month.
You're listening to the Tongue Tie Experts podcast, a weekly program providing information and support for those families impacted by tongue and lip tie and the professionals caring for them. I'm Lisa Paladino, a midwife and a lactation consultant with over 30 years of experience. If you are a parent looking for answers or a professional who is curious to learn more than what you learned in school on this topic, welcome. This podcast is for you. A gentle disclaimer. Please do not consider anything discussed on this podcast by myself or any guest of the podcast to be medical advice. The information is provided for educational purposes only and does not take the place of your own medical or lactation provider. Thank you. Welcome back, everyone, to the Tongue Tie Experts podcast. I'm your host, Lisa Paladino, and I am here today with Lori Overland. I'm very excited to have Lori on the podcast. We've been trying to connect for a while since I was invited to be at the Talk Tools conference this early in the summer, and we're now recording in August, and we're finally getting together. Lori Overland is a licensed speech and language pathologist, certified lactation counselor, and holds fellowships in orofacial myology as well as a neurodevelopmental certification. Lori specializes in oral sensory motor feeding therapy, oral placement, and orofacial myofunctional disorders in children. Her private practice, Alphabet Soup, focuses on infants and toddlers and preschool children with oral sensory motor feeding disorders. Lori provides international consults as well as consults to local school districts and Birth to 3 organizations. Her goal in addressing feeding and speech challenges is to improve the quality of life for both the children she serves and their families. Lori is a member of the Talk Tools Speakers Bureau and has lectured and presented posters across the globe, including numerous presentations at the annual convention of the American Speech Language and Hearing Association. Lori is a member of ASHA as well as many other professional organizations and holds degrees from Hofstra University and Adelphi University. Welcome to the podcast, Lori. Thanks for being here.
Thank you so much for having me, and I'm glad we finally were able to connect.
Yeah, and Hofstra, I never knew that until I got your bio. I went to Hofstra.
Grad.
Yeah. I didn't actually graduate from there. I went for 2 years, and then I decided to become a nurse, and they didn't have nursing at the time, so I came home. I often joke that I went to Hofstra to meet my husband. And then once I met him, I didn't have to be there anymore because we met first day of freshman orientation and we're still together. So
got a degree, you got an MRS.
Yes, exactly. Yeah, that's funny. So Lori, you have a diverse background and lots of experience. Do you want to tell my audience a little bit about your journey and how you've gotten to combine speech language pathology with lactation and the age group you're in? Tell us a little bit about that.
So I've been in practice for 43 years. And over the 43 years, I've seen infants, toddlers, preschoolers, and school-age children with special needs. And over the last several years, probably 5 or 6, I've taken that age group and gone down to the 0 to 5 population. Some of it had to do with COVID and just keeping the environment clean and having enough time. And I thought, where can I make the biggest difference in the lives of children, their families? And I decided if I get them really early on, I get to mitigate those long-term feeding and, speech and orofacial myofunctional issues. So my focus is primarily on infants and toddlers right now. I have a very good friend who you know well, Kathy Watson Jenna. And over the last 25 years, Kathy and I have shared countless infants. And it started out with either me calling Kathy or Kathy calling me, asking for some input, and then opportunities for us to work together.
I love that. I just want to stop and say, first of all, Kathy, for those of us who are IBCLCs, Kathy is like the greatest. Like she's my personal hero, as far as sharing knowledge and the pioneer that she's been, so shout out. And I'm not sure what the order of things is, but there is going to be a podcast episode we've already recorded with Kathy where it was amazing. But
Ray, I think she's like that person, that game show, like, you can call a friend.
Yes.
All things lactation.
Yes.
I would always call Kathy.
Yeah.
I didn't realize what a rock star she was until I was, long story about my grandson had some tethering and he was, born in a baby-friendly hospital in Pennsylvania. And I met the IBCLC and I was positioning my daughter-in-law and helping to get Noah to the breast. And she walked into the room and she goes, "Oh, the nurse told me you were having difficulty. I guess, you worked it out." And my daughter-in-law said, "Oh, my mother-in-law did it," which I was. So I said, "I can't take credit." I said, "Kathy Watson Jenner is my mentor." And she was like, "Oh,
right."
So I realized at that point what a rock star I am.
Yeah. And she's so humble and sweet and so giving of her time and expertise. It's really amazing. But the relationship that you're describing between yourself and Kathy is a relationship that I have with an SLP in my area. So I love this formation of the team and we learn so much from each other. But not everybody has the opportunity to make those connections. So, what's your advice for either a lactation consultant or a speech language pathologist who feels like they need to know a little bit about what the other side of the team would do? Like, what would you advise?
My journey, so I started this journey with Kathy, and our conversation was initially about children who had neuromotor issues, children with syndromes, children with tethering. It wasn't for your quote unquote typically developing or typical infant mother dyad. And at one point, I did my CLC just for knowledge base. I don't really think that gives you enough experience to practice, but it gives you a good knowledge base. And the more I learned, the more I realized I didn't know. So
I love that. The more I agree, right? The more you know you don't know.
Yes. And, that's happened to me at like various times in my career. With NDT, it happened. With my CLC, it happened. And now on my IBCLC journey, I'm back to like, I know nothing after 43 years. But Kathy said to me, why don't you at least explore the journey of being an IBCLC? Because so many lactation consultants don't know enough about infants with Down syndrome, with cerebral palsy, with cleft lips and cleft palates, etc. She introduced me to Dr. Christina Smiley, who is
another famous name.
And she was one of my mentors. And through here, I met Beth Ivanelli, who I'm actually in the room with right now. So that was kind of my journey. So, as a speech pathologist, we would get children who had feeding issues. Maybe they had already transitioned from breast to bottle, and they were having difficulty getting onto purees or getting onto solid foods. But when you listen to parents' stories, even though they got adequate nutrition into their infants, those feeding issues were present from minute one.
Yeah.
And, often those feeding issues are signs of like transition from birth issues, neurodevelopmental issues, structural issues, but nobody kind of connected the dots early on.
Yeah.
And, mother infant dyads are referred to IBCLCs to support the breastfeeding process, but a lot of times they're referred to us because they couldn't breastfeed.
Right.
So in that journey, we find out that this was a baby that wasn't able to breastfeed. And, we got them kind of after the fact. And retrospectively, those infants and toddlers who couldn't breastfeed have long-term feeding challenges. In addition to the fact that there are long-term consequences of not having been able to breastfeed.
My name is Martin Kaplan. I'm a pediatric dentist. I currently treat patients in Massachusetts. I've been a laser user for 17 years. Started out with diode lasers in 2003 to a second diode laser to a third diode laser, 3 erbiums, 2 low levels, and currently light scalpel CO2, which I used 6 years ago for the first time. I had no intentions of ever buying another laser again because I've had so many, and I never thought that light scalpel would change my life the way it did for the treatment of babies and all my other patients. And when I met Peter, I actually thought Peter was another used car salesman, and it turns out he wasn't. I gave him every opportunity to prove me right that he was a used car salesman, but he wasn't. And we've been good friends for the past 6 years, and I will not use any laser on anybody else except a carbon dioxide light scalpel laser.
Let me stop you there because I'm on this kick now of making this point that, we say there's lots of, swarming around with the saying fed is best, and we shouldn't be saying breastfeeding is best. And I keep coming back to breastfeeding is the biologic norm for life and for survival. And even if we choose not to breastfeed, if a baby, and that's everybody's choice, I don't feel like we should be forced, but we should understand that if a baby cannot breastfeed, that's a sign or an indication that something might be wrong somewhere with the baby. It's not the mother's nipples fault. It's not the taste of her milk. It's not the fat concentration of her milk. It's not anything that the mom is doing wrong. There could be something wrong with the baby.
It's so sad because I
Yeah.
can't tell you how many mothers land up in my office saying, "Oh, it's my fault. He couldn't breastfeed her." And I look at them and they say, "Well, I didn't produce enough milk."
Right.
One of the things Kathy Watson Jenner taught me a very long time ago is the breast are factories.
Yep.
Order in, order out. And so frequently when a baby has an inefficient latch because of something that's going on, either medically, structurally, in terms of their gut, in terms of their respiratory systems, any of those things, and they can't get to breast milk supply tanks. And
Right.
if you're not working, even if I was working with a mother infant dyad on what was going on, I still need that IBCLC. I still need someone whose expertise is in milk production, whose expertise is in, the integrity of the breast, whose expertise is in, positioning. And I've been lucky to have amazing mentors, and I carry that with me, that information, but not all SLPs do. And I think
Yeah.
we do a disservice. And it's not just about here and now. obviously breastfeeding is the best source of nutrition, and I will echo everything you said. But just in terms of immune support and gut health and the integrity of the middle ear, so many of our low-tone kids get recurrent otitis media. A lot better if you're not coordinating suck, swallow, breathe to have breast milk in your ears than to have formula.
Right. Especially related to the microbiome too. There's so many
Right.
layers of that dysfunction.
You
So
know,
yeah, you mentioned also that, that getting the baby when they're having trouble with either a bottle or purees or solids. And I get that too. I have visits that the parent will think that everything is, it's been a little struggle, but they've never breastfed before. They thought it was all normal. And they come to me saying the baby won't take a bottle. And I'll always start with, well, let me see how the baby breastfeeds, and taking the history. And when I take the history, the same thing you said, I'm like, oh my goodness, this mom has been struggling with this child for 3 or 4 months. And now is when it's coming out because this baby can't take a bottle. Even my own grandson, well, which I keep saying I'm going to have a whole episode on my grandson's journey, which it's been a journey, quite an adventure. Of course, my grandson had all the things, but he was able to breastfeed. He had a significant tongue tie, lip tie, which was his lip tie caused more of the problems, believe it or not, than the tongue tie. Very high palate, lots of torticollis and malpositioning because of a position he was in. And he could nurse. He caused pain, but he was able to transfer milk. And of course, I got my daughter's supported her supply, but he could not take a bottle. He couldn't even suck on a pacifier. He would not suck on my finger, couldn't suck on a pacifier. And I said to my daughter, good thing you wanted to breastfeed, because this kid would have been a tube baby.
Yep. I see that all the time, Lisa. People think not being able to breastfeed is the red flag. Breastfeeding is a diet, and every mom is different. And there are moms who their nipple comes out of the baby's mouth, and I'm like, okay, I'm in pain looking at that nipple.
Right.
Mom's like, you know what? I'm used to it. Or, their breasts are like torn apart. And, so everyone's pain level is different, and everyone's determination is different. I mean, there are moms who are like, I am going to breastfeed this baby. The other thing that you need to keep in, well, not you need to keep in mind, you know this, but the breast fills the mouth.
Right.
So if you have a baby that has a high palate, that has tethering, and cannot stabilize the bottle nipple or the bottle teat, sometimes that's a lot more challenging. And when babies do draw milk from a bottle, a lot of times they're using a compression release. If you listen to them swallow, it's like they're being waterboarded. It's actually scary to listen to that. So for a lot of babies, they're feeding all day long. They never empty the breast. There's a lot of compensations going on. They're only on the nipple. They have none of the areola or the breast in their mouths.
And they might be on the breast all day long, and they still might not be getting enough.
Right.
Right. So I talk about it like the hors d'oeuvre syndrome. You ever go to a wedding where they only pass hors d'oeuvres and you never sit down to a meal and you're starving when you leave, even though you ate all day?
Yep.
It's like that.
I mean, one of the great things that Christina Smiley taught me was a milkshake.
Yeah.
A lot of the moms I work with babies who have Down syndrome or have other chromosomal abnormalities or have really low muscle tone. That's really important because, those are your babies that fall asleep at the breast. Those are your babies that never empty the breast. I have moms doing hand expression, sometimes in the beginning, sometimes throughout the feed because they have compromised motor skills. But depending on the dyad, that sometimes works and bottle feeding doesn't work. Typically, developing babies who have no motor issues, they may have a really strong preference for the breast, but they usually figure out, if it's a working mom and they have to take a bottle, they usually figure out how to do both. And it's not, people go, oh, once he's on a bottle, he'll never go back to the breast.
Oh, that's not true.
That's not true for your typically developing babies. It's true for a baby who is so frustrated at the breast and can't latch. Well, it's the same thing with the bottle. I mean, I have
Right.
tons of videos of babies who couldn't bottle feed, but,
Yeah.
you
Yeah.
know, breastfed with lots of compensation.
Right. Right. Yeah. And as a lactation consultant, it's in my scope to take care of the transition to bottle, but I often refer them to my SLP friend because I'm not, and this is one of the things that I think is important to say, unless you've had specialized training in oral motor, I don't know what I'm assessing for other than the tongue. I know basic skills of what the tongue is supposed to feel like on my finger and,
Kathy is an exception.
right,
And
right.
she, and even when Kathy and I first started working together, I think she would tell you, like, I'm very specific about about a task analysis of muscles in the baby's mouth and what they are using in order to transfer milk, whether it's the breast or the bottle. And there's a lot of things we don't learn as speech pathologists, or a lot of things that are not specifically in our scope. And I think, as IBCLCs, I think that there's so many things you bring to the table, but I think our expertise in the oral musculature of the baby, and not just the oral musculature. I'm an NDT certified speech pathologist. What you see in the body is what you get in the mouth. So, when you come, sometimes it's an OT IBCLC team, sometimes it's an SLP IBCLC team, but it's being able to look at children who have neuromotor issues and, make adaptive positioning for them. Kathy and I actually did a presentation for Talk Tools on this, but adaptive positioning for children who have neuromotor issues so that they could be at the breast. And the sad thing about that, and this is really what piqued my interest, is not that every child shouldn't be at the breast. They absolutely should. But some of the infants that I work with who have compromised immune systems, who have, neuromotor issues, they need breastfeeding. I'm going to use the word more, but you know what I mean. They need as much, not more, than your quote unquote typically developing baby. And there's so many things that you get from breastfeeding in terms of the oral musculature. The breast shapes the palate. And for our babies who have, high palatal vaults because of tethering or because of low muscle tone, my children with a diagnosis of Down syndrome, it makes such a big difference if they are breastfed. And, it influences the flora of the sinuses. And if you think about how many children with a diagnosis of Down syndrome are in an open mouth posture because they can't breathe through their noses. And think about resting tongue position of not only babies who have tethered oral tissue, but babies who have neuromotor issues. A lot of your low tone babies are here. And some of them also have lip and tongue ties. But, breastfeeding encourages a more normalized tongue position, and it supports lingual mobility, and it supports facial growth. I mean, there's actually a great article. One of the other things I love about Kathy is if you ask her a question, she can tell you the day it was published, who published the article. And I can't do that, but I'm going to tell you a great article on the impact of breastfeeding on mastication.
Yes,
So
I've seen that for sure.
For my colleagues who don't know how important, they're like, oh, they got adequate nutrition at the bottle. And I agree, feed the baby. I mean, the baby
you have to, yes, of course.
But if I can work with an IBCLC and work on supplementing at the breast with the goal of getting that baby to the breast, even if it's only for dessert, as Beth Ivanelli would say, I want to get them to the breast.
Absolutely. Fill up that mouth with the breast and form the mouth and the whole oral complex, right? So I'm thinking of sometimes I feel like getting back to we don't know what we don't know, right? I had somebody message me, someone who's taken my professional course, who's an OT, and she's a wonderful OT, and she was called for a friend of a friend. Don't you love these? A friend of my friends of my friend had a baby, and the baby is in the NICU, and the baby has some kind of low tone diagnosis, and she's not transferring a lot, and blah blah blah. There's a whole story, and I'm just like, wait, stop there. She just was looking for a referral. Who do I know that does what I do where she is? And my first answer was, well, you don't need me. You need an SLP who understands, because when I hope things are different now, because I've been out of the hospital now, oh my goodness, almost 8 years, right? But when I was in the hospital, the NICU, the SLPs that came to the NICU, the only way they evaluated the baby was with a bottle.
Right.
They didn't even look. They didn't want to see a breast. They were like, oh, I don't want to. That's not my thing.
I mean, I think it's different for some SLPs.
Yeah.
What you're saying in the hospitals is probably still true. Kathy and I just did a presentation for the IBCLCs. Sorry, not Kathy. Beth and I just did a presentation for the IBCLCs at Danbury Hospital in Connecticut, and that's essentially what they were saying.
Yeah. And it was always like, that's why I didn't have a good relationship with any SLPs, because anyone that I saw who was an SLP, first of all, when they saw me coming, they were like, oh no, here's Lisa. She's the, like, they didn't have such nice words for me. Let's put it that way. Cause it was basically a bottle feeding culture that I was working in, even when it shouldn't have been. It was too late of a date to still be a bottle feeding culture, but it was. And they'd say, well, the baby's, passes to go home. I'm like, but the baby hasn't fed at the breast yet. Well, the baby takes a bottle, like signed off on swallow, the baby took a bottle, end of story, So I think there needs to be more collaboration. But my point was, getting back to this referral question, was I am able to recognize that I wouldn't want to be the first line for this baby. I want an SLP who's a feeding therapist.
So I think we need to do it together.
Yeah.
And I have testimonials from parents who have worked with Beth and I together, who say, I don't even understand how you could do this. Now, obviously, for years, I referred to IBCLCs and got referrals from IBCLCs. So when, the IBCLCs in this area, if they had a baby that was really premature, lately, I don't know about you, but there's a lot more 24, 25, 26, 27 weekers. Babies with respiratory issues, babies with severe gut issues, babies who had been intubated, your babies who have these bizarre syndromes. You're like, I've been in practice for 43 years. I have no idea what that syndrome is.
Right.
Delivery complications. I mean, so many of those.
There's so much birth trauma now. It's ridiculous.
Trauma, right. Things. I mean, so often, like, those are babies that I will see in conjunction with an IBCLC. I mean, my babies who have tone issues. And, when you're talking about the whole area of tethered oral tissue, it's not just us. I mean, it's us and a craniosacral therapist, because so many of our kids have plagiocephaly. They have asymmetry. If you have asymmetry in your hips, in your shoulders, in your neck, you're going to have it in your jaw, in your lips, in your cheeks, in your tongue. That's just the way it goes. Figuring out where that asymmetry is coming from is really, the challenge. Our babies with torticollis, I mean, so often they have, tethering, but so often it influences the entire oral musculature. I still need to be co-treating. It's not within my scope to look at breast distress. It's not within my scope to help moms maintain their milk supply. Certainly, I've learned a ton about light touch and a milkshake and self-expression because I've worked with amazing IBCLCs, but that's not my piece of the puzzle or my colleagues who are speech language pathologists. that's the part of the, the piece of the puzzle that I want to be in the room with an IBCLC. And we play off of each other. I mean, I'm looking at some things in the baby, they're looking at the mom, we're looking at the interaction together. And, Beth and I, we just have this thing, listen first. I mean, so often professionals walk into a room and all they want to do is talk. And on a podcast, that's great. In a room with a dyad, that's not great. I feel like the more we listen, the better off we.
Absolutely. I start off every consult with, tell me a story.
Story. Yep.
Tell me a story. And that's where the tissue box is needed, because there's often times, especially in these harder cases, where no one has actually ever asked how the mom felt about her birth or her pregnancy or what went on and what happened and what, how she feels about it. Not just what happened, I was induced and I this and that and the other thing. No, how do you feel about it? How are you doing with it?
I often get them after they couldn't breastfeed and somebody has convinced them they should be on a bottle. And so in addition to all of those traumas, they have the trauma of, I really wanted to breastfeed my child and I couldn't do it, and it's my fault because I didn't have enough milk to feed my baby.
Breastfeeding grief.
So,
it's really sad.
I used to say, tell me your feeding journey until I started to work with IBCLC. And now I'm like, tell me your birth story.
Yeah.
Pregnancy, and you're right. I mean, it's amazing what moms share because they just need to. I'm actually, as soon as I finished with you, evaluating a 12-week-old baby who was diagnosed with tethered oral tissue, and the parents are struggling with the decision about whether, they should have a release or not. And the mom, in her case history form, just talked about, the fact that she had a really hard time with the birth and that she couldn't get him skin to skin for, till like 2 hours after. And, even in the case history form, and that's not typical. Typically in the case history form, you get facts. And when you sit down, you get those stories. So.
Yeah, she's upset. She's upset and nobody's acknowledged that probably.
And I think, acknowledging that. So listening is number one.
Yeah.
And then looking. I mean, I always looked at the baby. I never really looked at the mom before I started working with IBCLCs. And there's so many things that you learn by just taking in mom's affect. That fourth trimester is a really tough time, not only for babies, but for moms.
And as you saw at my presentation that I did at that conference was What About Mom, and talking about how much a mom can handle.
Because it was so much of what, the IBCLCs in my life have shared with me that, I missed as an SLP. Nobody told me. Learned about, how mom looked, how mom felt, and pre-existing mental health issues that may be, impacting. Forget about the hormones from, just having given birth. So.
Yeah, there's so much. There's so much involved in getting a breastfeeding relationship. But yes, I totally agree that in the ideal world, we would all have like a central office where we have an SLP, an IBCLC, a mental health therapist, an OT, a CST, a physical therapist. We'd all be together. And there are places that have that.
Right. But that's not the typical.
Right. And you notice I failed to mention a release provider because that's such a small part of this. Yeah. And so many people, when I say, my company's tongue tie experts, they think, oh, you're one of those release all the ties people. And I'm like, no, I'm not, like it's about so much more than that. And
it's all about function.
Yep.
I mean, there are, Robin and I have had the opportunity to teach our 2-day course in tethered oral tissue for groups around the world. And, so often when we would be live, people would come up and go, can you look at my mouth? Because I have a tongue tie.
Right.
It used to be that if you saw something structurally, you released it.
Right. It's different. It's changing.
Listen, I mean, I think people, in 2018, when Robin and I wrote Functional Assessment and Treatment of Tethered Oral Tissue, I think people were really more looking at structure. And we said, you need to look at function and how that tethering is impacting health, how it's impacting nutrition, how it's impacting sleep and respiration and airway and feeding and speech. And, that's way more important. So, yes, identifying that there's a structural issue is one little piece of,
And for those in our listening audience who don't know, you're talking about Robin Merkel Walsh.
Yes.
And
my
if
partner in crime.
yeah, if anyone has the opportunity, to either attend something live or, read the book or the work that you two have done, you offset each other so well. I knew Robin before I met you, Lori, but like when I saw you two together, it's like, wow, you're such a team. And Robin's another speech language pathologist and totally smart and on top of her game. And your talks, together and apart are so informative.
Oh, that's so nice.
Yeah.
Yes, that's my partner in crime. And
Yeah.
she's brilliant.
Yeah. And Talk Tools is a wonderful organization that I'm just now getting my feet wet in that. I loved being a part of that conference.
Oh, good. Well, we loved having you as a part.
Yeah. I love speaking to speech language pathologists because I feel that the entry basic level of lactation is something that everyone should understand, not just lactation people. And that's why I open my course to all professionals.
I like speaking to lactation consultants because I feel like, once you get through positioning and latch and looking at those, those obvious compensatory motor skills and difficulty transferring milk and coordinating suck, swallow, breathe, and, looking at those babies, is it just a tired baby because they had a really traumatic birth, or is there something going on? And then delving deeper and saying, what is that baby? What does the palate look like? That baby, you may palpate those fatty sucking pads, but if you see deep contractions in the triangularis muscle, guess what? They're probably not accessing those fatty sucking pads. And then, looking at the shape of the tongue and whether it can support the breast. And so there's so many pieces of the puzzle that I love to be able to share with the people who are like on the ground level of feeding, helping facilitate breastfeeding for a mom and baby diet. I feel like it's such a big responsibility it's an honor, but it's also a really big responsibility working with, moms and infants.
Yeah. And it's also a big responsibility to be aware of other members of the team and know your place and when to collaborate, when to refer. And yeah, it's a good relationship. So I've taken enough of your time. I just want to thank you so much.
Thank you.
It was a pleasure to have you on. And we'll have in the show notes, we'll have your contact information and any links to the programs that you're offering now so that people can find you. Thank you so much, Lori.
Good day.
Have a great day.
Bye.
Thank you so much for listening to this week's episode of the Tongue Tie Experts podcast. Check out the show notes for useful links about the topics we discussed and for ways to follow us on social media. Please subscribe to us on your favorite podcast app. And if you enjoyed listening, we'd love it if you'd rate, review, and share with your friends and colleagues. Thanks so much. Bye-bye.
Hi, I'm Dr. James Thomas from Health Latch in Bellevue, Washington, and I've been using the light scalpel laser for probably about 3 years now, and it's been great. It's a tool that has really helped me help my patients. It works seamlessly. I can count on it every day that it's going to work properly on every procedure that I do. I originally started using scissors when I started, and eventually a diode, and now I use the CO2 laser because it's efficient for me and my patients. They recover really quickly. It's about a 24-hour turnaround, and I really enjoy that there's no bleeding at all, and so do the mothers that I treat every day.
Discover why the Light Scalpel CO2 laser is the top choice for tongue tie specialists. With unmatched precision and control, it ensures minimal discomfort and smoother healing. Elevate your practice with technology redefining tongue tie releases. Visit lightscalpel.com to learn more.